thanks to everyone for joining us, and it's for all the work that has come before us. And I particularly want to recognize Dr. Arciniega, who is up at 6 a.m. in California, as am I. So is there anybody else from the West Coast here? I don't see anyone. I know for Dr. Pararoti, it's 7. But in any event, this is very exciting, and I'll get my background fixed very soon.
Thank you. Rachel, do you want to get us started with a reflection?
I think this reflection is from Walt Disney this morning, very short and sweet, but makes a lot of sense regarding the work that's been done regarding the guidelines. Progress is impossible without change. With all of your work and just engagement, your expertise, we know that change will happen as it relates to this, this disease and this virus. So again, just thank you for being here, and let's learn a little more about Hep C.
Thank you, Rachel. I agree. This is progress, and every step in the direction of progress is very much welcome. So we have a couple of phenomenal speakers this morning. I will go through a little bit of the background and what the guidelines that have been shared include. And then I will welcome Dr. Kaderi as well as Ryan Crotis to give us a little example of some of the resources that are currently in existence in CommonSpirit Health that we can all take advantage of when we think about treatment of Hep C. So first and foremost, big thank you. This work that is going to be presented in front of you is certainly not done in isolation. It is absolutely the work and contribution of many members of the CommonSpirit Health family. So we have our clinical work group members, and these are folks who are subject matter experts, hepatology, primary care, as well as infectious disease, who live and breathe Hep C screening and treatment every day, and are also part of some of the nation's large committees on making a change in Hep C. And we will talk about why this is important. But also a big thank you to the partner teams. And these are all the folks who behind the scenes have helped us think about Hep C, have helped us make progress when it comes to leveraging the EMR, when it comes to leveraging resources that are in existence, what we call shared services, but also to really understand what are all the levers that need to be pulled to make the curing of Hep C, as you can tell by our background, that is our goal, a reality for all of us. So 2.7 to 3.9 million persons are infected with Hep C in the US, and majority of them actually don't know it. And this is data that comes directly from the CDC. Hep C is curable when treated early. So the paradigm has shifted when it comes to treatment of Hep C. And Dr. Kaderi will go through a little bit about how this paradigm shift has also increased engagement for primary care as well as subspecialists. But when we think about curing and treating Hep C, it is now a 2 to 3 month process for those patients who have non-complicated or are treatment naive and don't have any signs of cirrhosis or advanced fibrosis. If patients are left untreated, there's a significant risk for liver disease, right? 5 to 25% of those patients who have untreated Hep C may go on to develop liver disease cirrhosis. And of these, 4% would develop hepatocellular carcinoma. So really, when we think about oral medication treatment, it is life-saving, right? Definitely life-changing, but also life-saving by decreasing the burden of liver disease, cirrhosis, and hepatocellular carcinoma. So what is it that we want you to know? In brief, what we have done is that there is 2 aspects to the guidelines that we share. One is screening, and this is the screening guideline comes from the USPSTF, so the US Preventative Services Task Force, that has reviewed all the current data and has recommended that patients ages 18 to 79, and some may say 18 to and up, should be screened at least once in their lifetime. And the second aspect of the guidelines is the treatment. And the treatment now is much more simplified than what many of us have been accustomed to. And especially in patients who are treatment naive without cirrhosis advanced fibrosis, it is a very sequenced approach that is very much possible within the primary care world or the subspecialty world. So when it comes to recommended screening test, in the guideline, you will see what we have recommended is the screening test should be Hep C antibody. And if the Hep C antibody comes back positive, you want to quickly move into RNA or viral load if positive. The treatment for Hep C is, we have detailed it, and we will go through what aspects of the guidelines you can find this in, but really is a combination regimen, either over 8 weeks or over 12 weeks, depending on which one is prescribed and which one is covered by the patient's insurance. So Hep C screening, in brief, when we think about screening, we want to make sure that we start with Hep C antibody, and this chart is available in the guidelines, so you don't have to make a note. You start with the antibody screening, non-reactive, you're done, you're good, no HCV is detected, no further screening necessary, unless patient has further risk factors that develop that require continuous monitoring. If it is reactive, so Hep C antibody is positive, we want to go to the RNA, and if detected, we want to start thinking about current Hep C infection and then either linking to care, and that could be within primary care world, subspecialty world, but also other ways of linking them to care, which we will talk about briefly. If Hep C is not, RNA is not detected, but the antibody is positive, then no current infection, right? And testing as appropriate for other concerns. Also in the guidelines, what you will find is this idea of thinking about who within our primary care world we could treat versus maybe considering a referral to GI hepatology infectious disease. And you may ask, well, why are we thinking about treatment within primary care world? So two main concerns. One is that patients who are followed in primary care tend to be very much looped into care continuously, and you're less likely to lose that patient because you have the opportunity to influence the treatment moving forward. And second is, especially in those areas within our footprint and across the US really, where subspecialty care is limited, we have realized that this is an aspect of care that a lot of our colleagues and peers have been asking for, and we are now ready to move forward on this. So in the guidelines, you will see a decision tree that helps you decide which point should we refer the patient to gastroenterology, hepatology, or infectious disease, versus perhaps this patient would be the ideal candidate for treatment within the primary care world, and what is the recommended regimen. In the guidelines, one of the things is primary care. I practice primary care. And what I ask is, well, okay, it's one thing to prescribe a medication, another thing to actually understand what is required from counseling, medical evaluation, and at what point should I refer? So in the guidelines, you will find a chart. It's a one-page chart that says what to do at the initiation of treatment, and then what to do during treatment, and then at completion. And it's split up into 3 columns: counseling, medical evaluation, so what lab tests to order, does this patient require imaging? If so, what type? And also any other concerns of monitoring over time that's required. And then at what point should you refer the patient for subspecialty care? Because the patient's disease process may change and you may need to pivot to make sure that they are plugged in appropriately. And what are the next steps that we are asking of you? So first and foremost, we want to build awareness and we want you to share your knowledge. So all of you who have come through today to join us this early morning on Monday, please take a look at the guidelines. Read through them. I promise you they are brief, they are digestible, and then share them with a colleague, just one colleague even, or bring them to your practice meeting that you may be having this week, next week, or next month. The guidelines are available in 2 forms. So we have a direct link here, and also if you scan this QR code, you will go to the PE resource library, and in that library, you will find this guideline. You will find a lot of other guidelines too, but specifically this one is important to review. And the second, this link up here actually takes you directly to the Google Drive link, if that's what you prefer to go through, to the OpenShare guideline. If you have questions and you desire to have a more detailed understanding of why certain things are being recommended, or you have a special cohort of patients, whether that's a patient who maybe was not treatment naive, or a patient who may be pregnant, I do encourage you to go to the AASLD IDSA site, which you can go through here. It is a wonderful website. It is very well laid out, and I assure you, you can answer your questions there and also find the evidence that we have used to develop our clinical standard. Lastly, one major part of this work is making sure that the guidelines are not in isolation. And what I mean by that is that we are going to try our best to migrate these into the EMR in different ways and form. We are collaborating with our system clinical informatics teams, and a big thank you to them because they have been actively exploring all the ways in which we could migrate this and integrate it into the EMR. And we will continue to update all of you as we make progress in that area. What are the next clinical steps? So as we move forward in the town hall today, there are a couple of things I want you to keep in mind. One is we need to start counseling our patients that Hep C is treatable, and it is very important that we screen folks, right? Because we have a large volume of our patients out there who have never been screened but may be positive and should be treated. Next, enroll with Project Echo. If you are ready to take the step forward to say, yes, I think I would like to develop a niche practice, or I would actually like to treat this patient who is walking into my primary care or subspecialty world. Project Echo, which Dr. Kadari is going to talk about, is a wonderful resource. And it really leverages teleconferencing and case-based coaching to enhance your skill as a physician or APP, but also to bring care to patients who maybe have limiting access to specialists. Partnering with CommonSpirit Health Specialty Pharmacy, which Ryan Krotis is going to talk about shortly, is really a great resource. So if you have a patient and you're ready to prescribe the medication, but you need assistance when it comes to thinking about the workflow, prior authorizations, how do I make sure the patient has been brought in to the clinical environment and make sure that this patient is treated fully and has achieved cure, they are a great partner to explore, and we will talk about them shortly. But if you're not ready to take the step forward and you really want to make sure that you have good partners, start with screening and then at least refer the patient to specialty care so they can be treated seamlessly and quickly for their Hep C, because it is life-changing for them. I'm going to pass this off to Dr. Kadari. And it is my absolute pleasure to introduce her. Give me 1 second. So Dr. Kadari is an assistant professor and transplant hepatology medical director within the Division of Abdominal Transplantation at the Baylor St. Luke Medical College. And she's the medical director of our Project Echo program. So Dr. Kadari, welcome. We're excited to have you. And if you don't know Dr. Kadari, she is sort of the guru of Hep C treatment. And I think she is just a wonderful treasure of information. So looking forward to your presentation. We're unable to hear you, Dr.
Sorry, I should know how to work Zoom. I've been doing, especially with Project Echo. Let me just get my screen up and okay, let's try this one more time. Okay, and all right, we're good now, right?
Yes.
Okay, perfect. So I want to thank Dr. Sagar, Dr. Greenswick, and Rachel as well. I am so excited to be a part of this initiative. I live and breathe hepatitis C. You know, there's been a big push, especially with the, President Biden, to cure hepatitis C and eliminate hepatitis C from the United States. And so you're going to be hearing a lot more, both nationally and locally, about this initiative for elimination of Hep C. So again, I'm Dr. Kadri, I'm Saira Kadri. It's nice to meet everybody. I'm a hepatologist at Baylor. And I'm going to take about 10 minutes or so to talk about a program that we've been doing at Baylor in Houston for about 9 years called Project ECHO. So I just show this to you to help you understand kind of where we used to be with hepatitis C treatment. Not too long ago, there were many, many different medications. The combinations we would use would depend on genotype and even subgenotypes. Duration was different. And, you know, this was still much better than interferon and ribavirin days, but it was a little bit complicated. However, when you fast forward to now, really for the most part, we have 2 medications specific to this group. 100% of your patients will either be on sofosbuvir velpatasvir or glucapavir preventosvir, better known as Epclusa and Mavyret. And it's actually very, very simplified, the treatment. One of them is going to be 12 weeks for most of your patients, and the other one is going to be 8 weeks. So despite what you see in the background, Hep C treatment now is very, very much simplified compared to what it used to be. So I want to start by just talking about what ECHO stands for and a little bit of its history. So ECHO stands for Extension for Community Healthcare Outcomes. And the person you see in that picture is Dr. Sanjeev Arora. So back in the early 2000s, he was the only hepatologist in New Mexico. So if you're a patient with hepatitis C and you needed treatment, it would take you about 4 or 5 months to get into a visit for him. And he was the only person treating hepatitis C. And the way that New Mexico is set up, it was most likely that you were going to end up driving 4 or 5 hours to Albuquerque to see him. So what Dr. Arora found was that by the time the patients got to him, many of them already had cirrhosis and many of them had liver cancer. So what he did was he went through the state of New Mexico and specifically found primary care physicians, nurse practitioners, PAs, even pharmacists who were interested in treating hepatitis C. And this was back in the interferon and ribavirin days where the treatment was quite difficult. It was usually about a year long, many side effects and actually not very good cure rates. The best were about 40%. But he went through the state of New Mexico and found people who were interested in learning how to treat their patients for hepatitis C. And what he did was he did a teleconferencing system. So actually, we're all used to this now, many of us, especially after COVID, but back in the early 2000s, he had set it up. And then in 2011, he published his findings in the New England Journal of Medicine to show that patients who were treated in a lot of the rural spots with their primary care clinicians did just as well as patients who physically came down to the University of New Mexico and were treated by him. And so what he showed was there's no difference in care between university and community care. And the other thing he found was that there was this sense of community built among the providers. So many of these providers lived, again, in rural areas, did not have a direct link to an academic center. And now they had this link directly to a specialist that they would meet routinely. So it almost felt like they had a little bit of a family as well. So what is Project ECHO all about? So people need access to specialty care for their complex health conditions, but there aren't enough specialists to treat everyone who needs care, especially in rural and underserved areas. And again, he started with hepatitis C, so it's really the perfect example of this. So what ECHO does is it trains primary care clinicians to provide specialty care services locally. And so patients get the right care in the right place at the right time. And overall, this improves outcomes and reduces costs. So many patients who otherwise would not be treated because they wouldn't drive down to the academic center, they just didn't have enough time, were now getting treated. And I think that holds true today as well. Patients are more likely to feel more comfortable with their primary care clinicians than having to go to a specialist. So it's best to treat them in the primary care office. So it's not quite telemedicine. So telemedicine is more provider to patient, which again, many of us probably do now if we weren't doing before COVID. When I was in medical school, we would treat patients in the penitentiary system. And so like telemedicine can also be provider to provider. So we had a nurse in the prison with the prisoners who would then communicate with us and we would treat the patient that way. But Project ECHO is really considered telementoring. So it's more about learning, and it actually goes both ways. I learned so much from my primary care clinicians that participate in ECHO, but it's basically specialists that are training primary care clinicians to treat more complex diseases, right, like hepatitis C. And then we also learn from them about really real life issues that come up, such as lab costs, medication, and so forth. And it's a force multiplier because I myself can go into my clinic and treat one patient at a time. But when I'm able to help train multiple people in one meeting, and then they go on to their own clinics and treat multiple patients, it really is much more efficient and effective. And the good thing is that with each session, there's CME provided as well. And as Dr. Sagar had earlier mentioned, it's really case-based learning. So when I used to show this picture maybe 8 years ago, everybody used to be like, ooh, this is so cool. But obviously everyone's used to teleconferencing now. And we've actually been using Zoom the whole 9 years. So the whole time we've been using Zoom. So we were very comfortable when COVID happened. But this is basically how an ECHO session works. So different people call in. There's no patients involved in the actual ECHO visit. And it's all de-identified, HIPAA compliant information. And basically they'll present their patients and say, a 65-year-old man, these are his labs, these are the meds he's on. And then we help give feedback as to what treatment is best. So we currently have about 60 ECHO partners stretching from El Paso to South Carolina. But really, there's no distance that's too far. We could have people in Hawaii participate. We could have people in Africa participate, as long as the timing works out. So really, we can take on anybody who's willing to participate, really anywhere. We've had more than 2,500 case presentations, and the majority of our patients actually are uninsured. So they come from FQHCs. And so we're able to work with the clinicians there and get actually free medication for these particular patients. So really, I would like everyone to understand, like, we are happy to help with this hepatitis C treatment. If you want to join to just watch even and learn about how to treat hepatitis C, you can always join a session. If you want to present your patients and just get a little bit of feedback on if you're making the right decision or not, we're there to help. So our viral hepatitis clinic currently occurs every second and fourth Monday of every month, and it runs from 3:30 to 4:30 Central Time, and everyone gets 1 hour of free CME. So it's really great, again, for learning purposes, getting CME. The way that it works, everything is online. So you register and submit cases online, and we use REDCap. So when you're submitting cases, there'll be some questions about demographics, about medications, past medical history, labs, all different things that we should be thinking of when we're looking to treat someone's hepatitis C. Because our clinics are on Mondays, we try to get all the cases by Friday. Even if you send one in Monday morning, it's perfectly fine. I like to look at them over the weekend so I can be prepared for clinic. And again, you don't have to present a patient to participate. If you just want to log on, see how it's done, I think kind of the best way to understand how ECHO works is to join a session and see how we work. So this slide, I have 2 QR codes here. One is to register for the clinic. And this is just, again, when you register, you'll get the link, the timing, and the other one is to submit a case. And I can share this with Rachel as well later to disseminate that information. And that's really it. That's Project Echo in a nutshell. If you have any questions, please feel free to email me. It's just my last name at bcm.edu. And I'm more than happy to take any questions. And like I said, I really think it would just be great. If you're interested in Echo, just to see how it works, is join a session. And you'll see it's very much like a family. We all kind of work together and we all learn from each other as well. Thank you.
Thank you, Dr. Kadri. That was lovely. To sort of double down on what you said, is the idea that, you know, our primary care teams have so much talent and skill that this is a great way to further that talent and skill. And so thank you for engaging with them. Okay.
And I just want to say one more thing. Sometimes what happens is multiple clinics, like not everyone can participate because they may not have the time. But if you have one provider, one person per clinic, they can always submit the cases, and sometimes that works better. So there's many different ways to do this.
Okay, that's wonderful. It's a choose your own adventure concept. So I like it. Thank you. Right. And our next presenter is Ryan Crotis. So welcome, Ryan. Ryan is the system manager for clinical pharmacy at the CommonSpirit Health Specialty Pharmacy. And we requested him to come and speak to us a little bit about this hidden treasure within our CommonSpirit Health family. So welcome, Ryan. Thank you for being here.
Yes, thank you for that introduction. Ryan Crotis, I'm system manager for clinical pharmacy for CommonSpirit Specialty Pharmacy. I've been with CommonSpirit for about 10 years. All of it's been doing specialty pharmacy. So we're very excited about our program and hopefully we can help some of the clinicians out moving forward. A little bit about us. Slide, please.
And Ryan, there's a little bit of an echo. I don't know if that's fixable, but.
Don't know if it is or not.
Okay. All right. No worries.
A little bit about us. We are a dual accredited specialty pharmacy. So we are accredited with ACHD and URAC to basically stand for accreditation in specialty pharmacy. And our goal is to help patients through all steps of the specialty medication process. We currently have 35 licenses for states around the country. Our goal is to have all of the states licensed by the end of this year, with the exception of Arkansas. They have particular laws that will not allow us to get licensed there. Our clinical team is comprised of clinical pharmacists as well as a position we call liaisons, which help out with prior authorizations and financial assistance. And we currently have direct relationships with providers in Arizona, California, Texas, Nebraska, Kentucky, as well as taking care of all the specialty needs for CommonSpirit employees around the country. Slide. So a little bit about our care model. Patients that are prescribed specialty pharmacy medications are going to receive help with their prior authorizations, as well as financial assistance, with our goal being to take the copay patient responsibilities as low as can possibly be in order to improve their outcomes and their adherence. Patients that are eligible are going to receive initial and follow-up phone calls from our clinical pharmacists and liaisons, provide medication education, monitoring, to make sure that the adherence is as best as it can be and that they have great outcomes. We do have 24/7 service or 24/7 access to clinical pharmacists. So patients we call after hours, we can answer their questions, make interventions at that time, or refer them to the proper care if it's a need that we can't meet. We also have free delivery to the patient's home for the medication and their supplies. The clinicians and the clinic staff are receiving basically a dedicated resource. So that's going to relieve the administrative burden for the clinic and improve the outcomes and feedback, because we can, as an integrated specialty pharmacy, we can make updates through the EMR for our organization. And I think, as I mentioned, our goal would be to improve patient outcomes, increase patient satisfaction, and decrease the total cost of care. Slide. This is just a comparison of our specialty pharmacy to others. If you look at the first column there for onboarding, there's no real dedicated resource. Most other specialty pharmacies have basically whoever you speak to, you call, you might speak to one person, then you call this time. If you call a day later, you're going to be speaking to somebody else. We have dedicated liaisons and clinical pharmacists. So we have a one-to-one relationship with our patients. So no matter how large we get, patients are only speaking to 1 to 2 people every time they call. It makes patients feel more comfortable and confident in their care. We do proactive authorizations and financial assistance, and we hope that that leads to a 48 to 72-hour turnaround time to therapy initiation. That obviously leads to high patient satisfaction and better outcomes. For the fulfillment, we do offer patients to fill any of their specialty medications or other secondary medications. For hepatitis C, most patients do not decide to pull all of the medications over because it's such a short course of therapy now, but we do offer that service. And we're going to be providing support for medication adherence and, as I mentioned, the free delivery to the patient's home. For engagement and follow-up, we have the clinical pharmacy team that are making regular follow-ups and interventions and documenting this within the EMR. And that's leading to high medication adherence, particularly for hepatitis C. Next slide. This is just a breakdown of our clinical pharmacist interventions. So once a patient receives a medication, they're going to be counseled by a clinical pharmacist prior to the initiation of therapy. They are then counseled about 5 to 7 days later after the initiation to make sure that the patient is taking the medication correctly, they haven't started having any side effects, and they are making interventions at that time. And then we have follow-up assessments. It varies by disease state. We cover a lot of other disease states as well. But for hepatitis C, our clinical pharmacists are following up before each refill. So over the course of the 8 to 12 week therapy, a patient is speaking to a clinical pharmacist 3 to 4 times. And all of this can be documented in the EMR, as I mentioned. Next slide. These are the other disease states that we currently service. Our most common conditions that we assist with are oncology and rheumatoid arthritis, but hepatitis C is one that we obviously have capability to help with, as well as these other disease states at this time. Slide. So if you are interested in our services, the best thing to do is reach out to our director, Aaron Sharp, or myself, so we can set up that relationship and make sure that we can assist your clinic as best as possible and hopefully improve your patient's satisfaction and outcomes. Thank you.
And Ryan, this works anywhere in CommonSpirit, is that right? Whether I'm in Arkansas or Phoenix or California?
It doesn't. Well, as I mentioned, it doesn't work if you're in Arkansas because that is the only state that we cannot ship to. They have a very has a very restrictive policy on remote pharmacies, so we cannot ship to Arkansas. But all the other states, we should be able to assist by the end of the year.
Okay. And is there a solution for Arkansas?
Not at this time.
Okay. David, you're going to have to run out to the border and we'll send it right like to your neighbor.
Right. We've talked about things like that, but we don't have a great solution for it at this time.
Okay. We'll have to look for other opportunities here.
I just want to say we have this program at our hospital and it is incredible. It has taken out 99% of the work to get these medications. We just let our specialty pharmacy liaison know, give her the labs that we need, and these drugs are approved usually like less than 2 weeks even. So it's wonderful.
I wonder if we should, not to get us off the subject, but put the link to Ryan and Aaron and information in this primary deck so that when people are reviewing it, they know where to find it quickly.
I will make sure to send out the deck. And I also put Ryan and Aaron's email just in the chat for quick reference, but we will for sure send out all the information.
Okay.
So yeah, don't try to do that to yourself this early and try to remember, but yeah, we'll send it out. I think this is a good time to just allow everyone to unmute yourself and ask questions regarding the guidelines or the resources. Please feel free to do that now. Or you can just have comments if you'd like as well. Comments are okay too.
Yeah, I have a question, and it's for folks who are in the primary care world that Dr. Arciniega I see, and Dr. Parodi and so forth, Dr. Patel. Can you see yourself doing this?
I mean, I think for us, we definitely have a place for it. I mean, we definitely have a few GI specialists that we have access to. One particularly that specializes in liver disease. But you know, we are definitely primary care heavy in our medical group, Dr. Greenswag.
Mm-hmm.
So I mean, I think it would take just a little bit more education locally,
Mm-hmm.
but there's definitely some interest there.
I agree. You know, from Lake Jackson perspective, being southeast of Houston, this is very exciting. We did hear about Project Echo years ago, but just kind of got delayed from our standpoint. But we see the delay in getting care for Hep C patients. We do the screening. My biggest challenge and hurdle will be getting it covered by the insurance of what diagnosis ICD-10 to use, because we're getting a lot of pushback and a lot of bills from the LabCorp and other facilities as well too, as this is not getting covered. But I think it's a lot underutilized, and definitely I'll be sharing with my medical group as well too for a lot of the PCPs as well too. And I think that gives us, this guideline gives us that support in the backbone to say, you know, we can definitely treat the Hep C and when to refer. So I'm very excited about this guideline. So thank you.
Dr. Patel, I would say that the pushback, as time has gone on, pushback from the insurance companies has been less and less and less. You know, they had these strict guidelines about you have to have fibrosis at least stage 3, you have to have drug screening. All that is out the window. They don't require any of that. So with time, it has gone easier to get the labs and even prescribe Hep C treatment. And again, with this pharmacy program, it really makes it much easier.
No, agree. And yeah, and we just had a reflex. You know, I mean, I do the Hep C screening, but it was just a reflex to refer. But now we can definitely get them in, because I had a patient, high risk, didn't get any care for 3 to 4 months, and you know, just can't get into GI. So yeah, thank you.
I'm a pediatrician, and I've seen increasing numbers of women screened during pregnancy, and actually had a child that had Hep C and high viral count and responded beautifully to treatment. Makes me concerned about those children that we've not, you know, screened for. But of course, we're talking here adult primary care, and so my interface is with the moms. So.
And Ryan, your team does the medication prior auth, right? So if I call you and say I have this patient, and this is kind of directed to Dr. Patel's comments, it's your team that gets the auth and so forth.
Yeah, exactly. We would like to have a relationship set up. You know, you said it's just kind of cold that we might have to make sure we have access within the EMR. But yes, we'll go in the EMR, pull the data, submit, usually via Cover My Meds for the authorization. Then we'll also do research on financial assistance, make sure that, you know, copay cards, grant money, whatever we can do to make it affordable for the patient, we'll take care of that.
I wanted to ask Dr. Kadri, going back to Dr. Parodi's comment on pregnancy and women who may have screened positive, which to me seems like an important reason to bring that person back into primary care and make sure they're treated. your recommendations? Like, are you seeing this more often?
Yeah, so definitely, because you know, we show this chart. We used to just worry about baby boomers with hepatitis C, but it's bimodal now. So you have the 20, 30-year-olds, and then you have the baby boomers. So definitely women who, you know, could have children are getting hepatitis C. You know, there's actually there's a very small study that shows these medications are safe during pregnancy, but, you know, it's one of those, they found out they were pregnant after they had already taken the medication. So in the future, it may be okay to give these medications officially to pregnant women. So what we try to do is all pregnant women are supposed to be screened for hepatitis C. Now, whether that happens or not, you know, is unclear. The rate of vertical transmission is actually quite low. It's considered to be like less than 5%, unless the mom is co-infected with HIV. So what we try to do is we see a lot of these women during pregnancy, and there's really nothing to do at that time yet, but we encourage them to come back after they deliver. And we try to get them treated. Again, the breastfeeding recommendations with these meds is sort of, it hasn't been studied yet, should be okay, but hasn't been studied. But we definitely tried, that's a way that we get them into the system so that we can treat them after they deliver. But the hope is that, you know, we're trying to streamline everything. Point of care testing eventually, you know, one visit for a diagnosis, here's your meds, we'll see you in 8 weeks or 12 weeks. So the goal would be to get these meds approved, hopefully when mom is pregnant, because that's when she has insurance, that's when she's engaged in medical care. But for the time being right now, we try very hard to get them to come back after delivery.
Thank you so much for the insight. Ryan, I wanted to ask you a question because I think this is something, when I wear my primary care hat, I always tend to fall into, which is medication interactions. Does your team sort of go through and make sure, like, all the meds this patient's on and they're okay dosing wise and all that good, like, pharmacokinetic things that I probably miss more often?
Yeah, absolutely. I think my connection's jumping in and out, so I'm sorry. But yes, our pharmacists are taking a look at that because we have access to the EMR. You know, when we get a prescription, our pharmacists are going in there. We're looking at labs, making sure that those are appropriately done, checking for those drug interactions, making sure everything lines up before we send the medication. So we're doing all of that. Kind of the last check just to cover our bases.
Yeah, and the good thing about these meds is there are not many drug-drug interactions. The most common thing you'll come into contact with are the statins. But Dr. Sagar, you showed that you showed the Liverpool app, which is very helpful. And even Lexicomp, you just put all the medications in and it'll do a quick interaction. But again, these meds overall, minimal drug-drug interactions.
Fantastic. Any other questions, comments, feedback? I know it's really early in the morning, but obviously we all are very much here and present to answer any of your questions. I'm hoping you all know how to reach out to, of course, Dr. Greenswag, who is our leader, our fearless leader, and then Rachel and my
fearful leader.
Rachel and I are obviously here to support all of you. So please reach out with any feedback, constructive or otherwise. We welcome it. And I wanted to say a very big thank you to both Dr. Kadri as well as Ryan Crotis for joining us this morning and really doing this amazing work for the last few years, trying to stand up just two fantastic resources that we can leverage.
And one thing I would add is that Dr. Sagar and I and others on the team are working across the system to put together all of the clinical leaders for the various medical groups in Arkansas, Phoenix, California, and so forth, to help us do this work and particularly this hepatitis C project. And so we hope that will add some additional support. We're going to bring that group together in actually sort of a work group, particularly around hepatitis C implementation and other clinical standards as they roll forward. So we feel that we need some infrastructure, and that these town halls are great for introduction, but we need a place where we can really kind of manage. And our goal in all of this is to get this information and support to people who are on the front lines of care for their patients. And so I think that's we don't want it to be just kind of top down, like here's a guideline, we hope you follow it, but we really want to support people in the process. And just a big thanks to this entire team. I know Hannah Burns from Pop Health is on, and she and Jesse Singer, who I see his name, but I don't see his picture, helped us with the data and kind of the early analysis of this work. So it takes a village. And I think Dr. Sagar talked about that in the beginning, and Rachel and the entire team. So thank you all.
Great, thank you so much. If there are no more questions or comments, we thank you so much for joining Town Hall. We will have another Town Hall on Wednesday, the 19th. It's 5 p.m. Pacific time. And then we're also preparing for grand rounds on July 14th that will also talk about the guidelines as well. So please feel free to join us or share this information. We will also send out the slides with links and things if you weren't able to catch them. Have a wonderful Monday. And again, thank you for joining.